This is Alissa.
Neal.
Caroline. Laura.
And this is Maritess. Welcome to Med-Surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud Med-Surg nurses just like you, sharing our stories, insights, and experiences to support you in your nursing journey. We welcome you to this episode of Med-Surg Moments. Parker is working and unfortunately couldn't be with us, but it's great to have back with us Laura and Maritess, our two special guest co-hosts.
Thank you. Happy to be here.
Thank you.
Great to see you both again. Well, we're going to start this episode on a bit of a downer because this episode also happens to be Alissa's final episode as co-host. And for those of you that have been with us, Alissa has also been with us from the very beginning when we launched Med-Surg Moments back in February of 2019. Hard to believe we're coming up on 3 years. Alissa, what memories and wisdom would you like to share with us?
That is a really loaded question. It has been so fun doing this over the last 3 years. And I have learned so much about myself, about this process of making podcasts. And I have had so much fun just in this platform, getting to know you guys, having a lot of fun with the co-hosts, and just really networking and advancing my relationships with AMSN in general. That has been really amazing. Wisdom, I don't know, I've grown, I feel like a lot. I've had to learn about making sure that the things I say, I can support and believe. And sometimes it feels like linguistic gymnastics because I don't want to get myself in trouble with my organization or.
That's why we have the disclaimer,
Yes, exactly. Right. These are my thoughts and opinions, I swear. It's been such a wonderful experience of professional growth and finding other like-minded people to discuss this with. It's hard to find people in this industry that just want to chitty chat about Med-Surg. So that's been really fun too. It's just been a really amazing experience. I'm so grateful to AMSN for the experience for sure.
For myself and our special guest co-host, what advice would you have?
What's really important is making sure that you have a position. For me, I always came into this from the position of education and wanting to teach and share my knowledge and experience with people. And so I think if you're coming into this with a perspective, you want to share your experience, you want to share your knowledge, you want to help people gain something from you. And I think that really helps. And then sharing stories. We all learn and gain from more stories. And I think for me, I felt like I was getting to a point where my war stories were all the same because I'm not at the bedside anymore. So you kind of get to a point where it's all my stories are the same. And I think that our audience could really learn and grow from different stories and different perspectives. That's where you and Laura and Maritess come in to keep advancing our story for this podcast.
Yes, I would have to say, glad I'm back at the bedside to add even more stories, especially in a nice position like float pool, where you get to go to all these different facilities and experience different things.
Absolutely. And so you're going to have a lot of variety to share and a lot of things that people can gain from you. So I think that's wonderful.
Thank you for that advice. Great advice, really.
Okay, well, enough about me. What's new with the rest of you guys? Caroline, why don't you start?
All right. Well, it's been a bit of a whirlwind for me. I think the last podcast I was on, I just landed in Georgia, relocating from Florida. Had a few bumps along the road, but since then I've got settled into my new role as a clinical manager. So I'm trying to sidestep from education into clinical management and all that brings. I'd forgotten all about staffing and scheduling and staffing and scheduling. So that's been a big learning curve for me. We moved again into what I hope is our forever home. And now here we are, finally settled, or as settled as you can be. So that's been my big update.
That's awesome that you finally got into your forever home, hopefully.
I hope so. I really do. Neal, what
Quite
about
a journey.
you?
Since last we podcasted, I've officially put in my application for my MSN at Duke University. Lifelong Duke fan for basketball, so I'll be excited if I ever get tickets to a game.
What specialty? What are you going to do?
A nurse educator.
Yes. Yeah, we
Falling
need
back
more.
on my education prior career. I believe they require you to go there 1 week a semester. So hopefully there'll be a March Madness weekend there somewhere and really enjoy the experience. So cross my fingers. Went to a trauma training class today at my hospital, starting to step a foot into some maybe ICU trauma training and maybe be cross-trained to be able to float to other parts of the hospital, which was very, very interesting. Opened up my eyes. I love that about nursing. There's always something new to learn and something changing all the time. Evidently, there's a new lab. Basically, when you're in a trauma, you're just dropping all this blood and platelets and plasma in people. The new lab breaks down, oh, you need more platelets than packed red blood cells. And so you're not just dumping blood products in this person. I thought that was just amazing. I never knew that that wasn't a thing, let alone that there is a thing now. So I'm just excited to hear about Duke hopefully soon and making it through the holidays.
Right on.
And how about you, Laura?
Oh, well, nothing as exciting as that for me. All I'm doing right now is trying to get ready for Christmas. It's a different ballgame when your kids are not little. I thought it would be less work, but trying to come up with ways to get them excited about things that they used to get excited about. They don't care. No one wants to bake cookies this year. My kids are 19 and 22, and they're just like, tell me where to come, where to show up, and how do I get my presents? So,
yeah, I can relate to that for sure.
Those of you with young kids, enjoy it while you have it, because it's never going to be that magical again. But outside of that, work is going well. Like I said, I'm about 3 months into my new position. I'm feeling like I have my feet underneath me. So I'm getting a hold of this nursing professional development gig. But they told me today I really need to start studying for my certification exam. So that'll be something fun coming up for me.
You got it, definitely.
Yes. Maritess, what's new with you?
My family and I are huge Disney fans, but we tried something new this time. So last month we went to SeaWorld Orlando. So my kids are very excited to see Sesame Street, but guess what? Something new came up. I'm the one who's very excited because I grew up with Sesame Street. So I was like, okay, looks like I'm changing from Disney to SeaWorld. So right there, we purchased our annual pass. So perhaps that will be our gig for the next year, 2023. It's exciting.
Very exciting.
Right on. That sounds awesome. Well, why don't we move on to our topic? Today's topic is one that I suggested because apparently I have problems. So alcohol use disorders, right up my alley. And since it's my topic, I thought I'd start with a little background as to why I chose it. I was designing education at work and Stuart emailed me for a topic and that's what I had. So great.
Well, I know for alcohol use disorders, one thing that we focus on is assessment. Like when you have patients coming in, sometimes people tend to gloss over those questions and not realize how important it is to ask those questions appropriately and to recognize that patients sometimes don't always tell the truth. Do what you can to make them feel comfortable. There's no judgment here. If you drink 5 drinks a night, then that's okay. We just need to know.
Nurse.
Well, shh, that's a secret.
I wasn't speaking personally.
Yeah, exactly. Well, and now's not the time to think about how many times I've talked about going home and crying in the shower with a beer after a shift. Really, in all seriousness, right? We can sit here and crack jokes about alcohol use disorder, but the fact is that it is a medical condition. It is a brain disorder. And ultimately, as healthcare providers, we need to know if our patient is having an issue with alcohol because we need to watch for alcohol withdrawal syndrome while they're in our care. Alcohol withdrawal syndrome can be very dangerous for us as healthcare providers if we don't know what's happening. And so that's really why alcohol use disorder becomes an issue for us as healthcare providers when we're caring for people with it in the hospital setting.
Yeah, it's absolutely essential that we screen our patients correctly. We have a patient at this very moment on the floor that I'm on who came in having fallen and broken a bone. And of course, the more questions we ask, the more we realize that she had a history of falls late in the evening after she'd been home, had a few drinks, got up unstable. And this one was the big one, so to speak, in that she broke some bones. But it took a little bit of coaxing for her to admit that there was a connection with an alcohol dependency. And what was she going to do in the hospital? Because she knew that it was unlikely she was going to get any alcohol. And so, of course, that's where DT protocols come into play along the way to save her from going through some nasty signs and symptoms of withdrawal and everything that goes along with that. So disclosure is really, really important and easier said than done sometimes because our patients just don't feel comfortable doing that.
Yeah, I agree with you, Caroline, when you mentioned that full disclosure is so important, because how can we really take care of them if we don't know the history behind everything? And, with Laura's point that they're not telling the truth. And so as nurses, we previously talked about this, that we need to remove the stigma that it is okay. Not that it's okay, but it's okay to talk about it because we want to take care of you. We wanted to make sure that we provide the care that you need. And I want to share a quick story about not really a patient, but I was in a hallway by our office and he was saying he's having a seizure. And I was like, are you sure you're having a seizure? I can see the color is yellow, like he's very yellowish. I can tell he's having some jaundice, and he's saying that, I'm having a seizure, but I'm okay. I have my meds. And I saw like the meds that he has. And he was like, oh, I'm sorry. This is not mine. This is not really mine. And I said, I touched his hand and I said, it's really okay. It's really okay. And he started getting dizzy and I had to call 911. What really helped was when I touched his hand, I reassured him, it's okay. I'm getting help. And then I didn't realize he has his luggage by his side. I didn't realize that he's from another state. And so many things happening right there, but understanding that as providers, being there for our patient, not really judging our patient is, I think, our first step. And then, of course, for the patient, once that is established, they can gain the trust. And so they can have that full disclosure and trusting us that we can provide the care for them.
Yeah, to rebound into that, I had an experience once. One of our, I hate to use the term frequent flyers, had came in, longtime alcohol detoxer. I was still an LPN. We used to work under a RN LPN model. And he's literally signing discharge papers. And he just gets this glossed over look. And he's like, I don't feel so good, And I'm just like, oh, you're probably just nervous going back out after a week of being in here. And literally with the pen stroke, his eyes just rolled to the back of his head. We had to get out of van, giving him IM, turn him on his side to make sure he didn't bite his tongue or choke or anything like that, out his vitals. He ended up having to stay an extra day to get the back of his head patched up. And it was just one of those moments you think, oh, we're out of the clear there. We're out of the forest. And, he turns around and has a seizure and you just never know when it's going to happen. And like I said, it's so important, that initial assessment. And the infamous 3 bottles, is that 3 8-ounce bottles or is that 3 40-ounce bottles? I think it's the big question when we're doing that proper assessment of coming in and making them comfortable enough to admit, like, hey, this is what I do every day after work or whatever it is, like drinking. I always felt that alcohol misuse is so easily accepted, since throughout the country, there are so many different ways that we indulge in alcohol, whether it's a glass of wine with dinner, beers at a football game, when you're sitting out at the beach and having a drink, a margarita by the pool. It's real easy to get a disuse as opposed to use. And thank God for programs like Al-Anon or AA, Al-Anon for people in a relationship with an alcoholic. And my thing I always think about with detoxing somebody is making sure that day 3, you know what it is, they last had that drink too. That's when they will pop like a tick. And one of my favorite sayings for it too is you can't unpickle a pickle, with Wernicke's Korsakoff's there.
Neal, I think you bring up a really good point, and something worth discussing is that alcohol withdrawal actually comes in stages. In our medical community, we look at it in a mild, moderate, and severe withdrawal. And the mild part often just looks like a hangover. It's with those first 6 to 12 hours after their last drink. But it progresses, right? They get into those moderate symptoms 12 to 48 hours after the last drink. And then that severe 48 to 72 hours, which you were just talking about. And it's unfortunate that we're aware of these timelines. Our doctors would no, we got to get him out of here. We got to get him out of here.
Double stat.
Yeah, let's get him out of here, because they didn't want to have to deal with that severe withdrawal when they felt like it was safer for the patient to just go home and start drinking again.
Yeah.
Because when you can identify that this patient is not going to continue a life of sobriety, it's almost more dangerous for the patient to go through withdrawal, because withdrawal is so dangerous.
Which is amazing. I remember learning in nursing school and being baffled that you are more likely to die from alcohol withdrawal than drug withdrawal. And I'm like, what?
Yeah. Yeah, that was really shocking to me as well.
It's categorized as a disease of brain function. It's a neurologic disease. It's an illness. And it requires not just medical intervention, but psychological intervention as well. And as Med-Surg nurses, we're great on the medical side of things, but we miss out on the psychological component unless we happen to have a psych facility that our patients can be transferred to. And just in the way that withdrawal is mild, moderate, and severe, the dependence on the alcohol can also be mild, moderate, and severe. That can be categorized as well. And there's a staggering 14.5 million Americans, 12 years or older, 12 years of age, have alcohol use disorder. So says the Cleveland Clinic. Wow.
I'm very lucky. I'm fortunate that I have a psych background on top of my med-surg background. So when they're on the med-surg floor, it's kind of old hat for me to pick up on something like that. But I've definitely seen med-surg nurses struggle, like I said, not realizing what's going on. And I tell you, lately, I've been noticing a lot more doctors prescribing lithium as opposed to Ativan. I mean, it's still within the benzos family, but I think they've gotten such a tolerance to Ativan, a lot of drinkers, that they've finally switched it up, which I think is a great solution to it. Not only that, but I feel like they've gone with a taper. So, because CEWA, unless you've had really good trainings with the withdrawal scale there, it could get real foggy for some people. What's a tremor? What's sweating? Their anxiety levels. So I feel like it's a really good taper nowadays that they use, at least out on the med-surg floor.
I'm in a really heavy orthopedic world right now. And as I was just sharing, when patients are falling, they eventually break their bones. Is it connected with alcohol? If we look at the etiology of the disease and what causes it, scientists are really still trying to figure that out. It does appear that there's a combination of genetics, traumatic events in childhood that lead to alcohol dependency, or attempts to relieve emotional pain or block out the real world, or some people will use alcohol as a coping mechanism because of that initial euphoria and everything's right with the world. And then, of course, crash, bang, wallop, and you're going into DTs before you know it.
Well, because you develop that tolerance and then you need more and more of the drug, of the alcohol use to get those same effects. So they just keep chasing and drinking more and more and more to try to achieve that same effect.
Exactly. And I think I said on the previous podcast, it's not difficult to get a hold of alcohol. I mean, those statistics there with young adults age 12 and up, you think 12-year-old. It's not that hard to get alcohol. It's readily available. And you don't necessarily have to go to a liquor store. It depends on what state you live in. In Florida, when I was there, you could buy liquor right there in the grocery store. You didn't even have to go out of your way to find it. But it's usually hiding something, I think. People use it to cover up. And then, of course, they're likely to develop alcohol disorder when the earlier they start using it with some kind of trauma. Or, of course, if there's a family disorder, there's a very fine line, as Neal was just saying, between having a glass of wine at dinner or getting through the whole bottle. If someone grows up around that, I don't think there's anything wrong with that. But then the amounts increase and increase and increase.
Yeah, that's important when you're doing that initial assessment, is defining what one drink is.
Yes.
Because some people will be surprised, when you're pouring a glass of wine.
Yes.
How big is that glass?
And I think when we try and look at the symptoms of alcohol use disorder, they're very variable. I think the more recurrent episodes that patients will tell you that they blacks out, they can't remember anything, that they know it's not good for them, but they love how it makes them feel. All those little key points indicate you need help.
And it's not necessarily just those people that are in that demographic. If you've got a college student in front of you, you're more likely to believe that they're an alcoholic or that they might have a problem with alcohol. But you could also have a 40-year-old woman sitting there who's like a soccer mom and seems to have everything under control, but that person can be at risk as well. So we can't just gloss over the fact that they don't look like they might have a problem with alcohol. We have to ask the questions.
Well, and I think what's important about alcohol use disorder is that it is characterized by the inability to stop or control alcohol use, despite the adverse social, occupational, or health consequences. It may have several different names like alcoholism or alcohol use disorder or whatever you want to call it, alcohol abuse. But it really is the brain disorder that is caused by chronic alcohol use and the impact it has on the neurotransmitters that cause lasting changes in the brain that make the individuals vulnerable to relapse. It can impact anyone, the soccer mom, the college student, the pastor at the church. It doesn't matter.
Well said.
I think we also wanted to touch with family members, the codependency. If it's part of their culture, if it's part of what we do as a family, and so they wouldn't recognize that this is a disorder. This is a norm. This is part of our society. And so if you share with them, this is a disorder, this is what we need to do to care for your family member, they dismiss it because they realize, this is normal for us. And so I think it's so important to assess codependency as well, assess family members as well who are enabling.
Yeah, you mentioned one of the things that I always like to touch on, and that's culture. What's the social norm for some cultures, and in others, it's considered highly offensive. I grew up in Europe, and it's just commonplace to have wine with dinner. You don't think anything of it. And then places that lived in the United States, especially in the Bible Belt here in Georgia, there are some people that you can't even say the word alcohol before they want you to sign up for a 12-step program, So I think that's something to consider as well.
There's times when we know that we're not going to cure their addiction to alcohol, but they're still in the hospital for some other problem, some kind of infection. So if they're in the hospital for longer than a couple of days, I can remember a doctor writing a prescription for 1 beer with their dinner or something to that effect, just to stave off those effects while we're treating them for their other infection. So that surprised me as a brand new nurse when I saw that order. But yeah, there's alcohol available in the hospital.
It depends on where you live, though. That is not allowed here. Yeah.
Wow. I actually have an actual doctor's order to give 1 bottle of beer and a banana.
Nutrients in there.
Potassium. And then to add green leafy vegetables to do well with the B12 instead of just giving a banana bag, right? That's how we call it. And I was like, is this real? I had to call the doctor and clarify. And I was like, yep, get a bottle of beer, a banana, green leafy vegetables. And I was like, they're serious.
It's a good nurse questioning that order. Good job, Maritess.
I love that. Good clinical
Practice the questioning attitude.
Yes.
Way to clarify. No, so I actually have seen an order like that too. Our pharmacy was like, we can't do this. Like, this is not legal here in this state. And the physician was new to our organization. He was like, what are you talking about? You can't do that. And I'm like, no, we literally cannot. And he's like, okay, well, he can have a family member bring him in a beer then. And I was just like, do we all turn around? Like this is literally illegal. We can't do this here. So it was very interesting because I feel like in terms of patient care, it really would have been the best care for the patient. But you get stuck in that hard spot of this is not legal here. And so, now we want to rush this patient out before they go into withdrawal because ultimately it's more dangerous for the patient to stay in the hospital and go through withdrawal than go home and drink beer.
Oh, yeah, absolutely. And that's something that we mustn't forget either. And if patients don't disclose on admission and they're having a surgical procedure, general anesthesia will delay the effects of a withdrawal. And just when you think you're going to get them out the door on their way home, then they have a really serious withdrawal event, which is terrifying for anyone to see.
That actually reminds me of a situation with a patient who was lying about his substance use.
Yeah.
I think it was more than just alcohol. I think he had also been hiding pills and stuff in the room. But ultimately what ended up happening is post-surgical, he came out with locked-in syndrome. So it was crazy. So sad. Yeah, it was post-surgical that we were like, this makes absolutely no sense. And they started going through the room and finding all the substances and stuff.
Unbelievable.
Do you guys use the CAGE assessment? I think that's very important for nurses to understand, normal conversations with patients. We use the CAGE assessment as part of the documentation, but we try to teach the nurses from an education standpoint. Don't make it sound like a tool, make it sound like a normal conversation. Like, hey, have you ever thought of stopping, the drinking? Have you ever thought of like cutting down the number of drinks that, you're thinking, or the perception of how many drinks are you really drinking, right? Are you getting annoyed? Are you guilty? When you wake up in the morning, do you think of drinking alcohol? And so I think that's also very important to just kind of like make it like a normal conversation for them, but then you're really assessing if this patient is really having an alcohol disorder.
So I'm sure there are a lot of different assessment tools. We don't use the CAGE assessment tool in our facility. We use the brief alcohol withdrawal scale, or the BAWS assessment, and that's paired with a pause assessment for the provider. So the provider will put in that initial assessment, which will trigger the nurse to follow that up with a brief alcohol withdrawal syndrome scale. But I'm sure there are so many, because before we moved over to this, we were using a different one that I can't remember right now because I'm so amazing at the bedside. I'm sure it's been too long is really what I'm getting at. I don't chart anymore, but lots and lots of different scales that we can use for this.
They were talking today in this trauma class, and they had a patient come in who was at a bar, fell off the bar stool. When he got to the hospital, became very combative. So they're going crazy trying to find a blood alcohol level, sedate him, give him Ativan. This behavior, though, came actually from a subdural hemorrhagic bleed in the brain. That frontal lobe pressure made him combative. Luckily, somebody kind of pushed the alcohol to the side and said, wait, there's something else going on. This wasn't what he presented at when he fell. And so I think a lot of times with drug and alcohol use, there could be such mimicked behavior. Sometimes it's hard to either say, is this alcohol or is this something else? So we think about with psych drugs too. Sometimes we overdo it with psych drugs and they can have some of these odd behaviors. So sometimes it's with alcohol use, like people kind of downplay it, or people like, they don't think of having a glass of wine or two as a problem. And so it's very easy to have that person start getting a little bit frisky towards the nighttime when they start withdrawing.
That's funny, Neal. It sounds like you went to ATCN. That scenario sounds pulled straight from that class.
He was.
Okay, awesome. But you actually bring up another very valuable point. My experience on the floor as a trauma nurse, that's exactly it.
Yeah, then it was that.
We can't clear a patient. We can't clear their spine. We can't rule out injury while they're intoxicated. So half the time they'd be admitted just to sober up so we could figure out if they really had an injury. So that's a very valuable point.
Once again, believe it or not, we're just about out of time. Before we go, let's quickly summarize what we have learned today. I think the first thing is it's important to do an assessment when our patients come in to determine their alcohol use and daily value. Also very important to encourage full patient disclosure. We should never judge, of course. Alcohol use disorder is a medical condition as well as a neurologic condition, and we must always be on the lookout for alcohol withdrawal symptoms or syndrome at any time. The other component, of course, from the therapeutic perspective is to reassure our patients that it's okay to talk about their dependency on alcohol. Reach out to them, ask those open-ended questions, build trust, and make patients aware that we have resources to help them if they feel like they're ready to move forward. The progressive stages of alcohol withdrawal are also very important. What's one drink to one person might be 6 to another. So that's very important to understand that. And, believe it or not, it's sometimes safer for the patient with alcohol withdrawal to go home and drink rather than stay in the hospital. The CAGE assessment is one standard assessment tool, along with other assessments depending on what your facility uses. So, Alissa, it's the end of a remarkable road for you here on Med-Surg Moments. Any parting thoughts as you go on your way?
Oh, man, it's just been a really amazing experience. So I am so grateful to you guys, and I am going to miss you. And I know I'll be thinking about this while I'm working on my dissertation because I'd rather do this. So
maybe down the road you can come back as a special co-host.
There you go.
It'll be so worth it when you're done.
Well, I appreciate that. And since this is my last one, let me be the one to say we thank you for joining us on this episode of Med-Surg Moments, the AMSN podcast. We look forward to connecting with you on our next episode of Med-Surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback via our official Med-Surg Moments email address, amsnpod@amsn.org. That's amsnpod@amsn.org.
We'd also like to remind you to become a member of AMSN or renew your membership at www.amsn.org. You'll receive lots of cool benefits and perks, such as discounted pricing on the annual convention and continuing education.
We encourage you to help us spread the word and subscribe to the Med-Surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review and recommend Med-Surg Moments wherever you get your podcast to help us reach even more listeners.
I invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages. And don't forget to add hashtag Med-Surg Moments to your posts.
The content within the Med-Surg Moments podcast represents the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses. Until next time, always remember, Med-Surg Moments is a moment in our lives, a moment in our Med-Surg careers that makes a huge difference.